Well, welcome. Thank you for joining us on our first Facebook Live. I'm Russ Ferguson, U.S. Attorney for the Western District of North Carolina, and we're here today to talk about all things fentanyl. So Friday, the 21st, is National Fentanyl Awareness and Prevention Day. We're kind of making a week of it here and talking about fentanyl because as I go out in the community, it's amazing. Everyone I meet knows somebody who has lost someone to fentanyl, and I mean truly lost a life to fentanyl. So let me introduce who we have here today. I'm so glad to have this panel with us today. We have Eric Conaway here. He's an Assistant Special Agent in charge of the Drug Enforcement Administration, the DEA. He's in charge of all of North Carolina for the DEA with us here. We have Dr. Corey Hines. Thank you so much for joining us, Dr. Hines. Dr. Hines is an emergency room physician for Atrium Health, and so he's here to talk to us about overdose and what to do when you see someone overdosing and kind of the medical aspect of it. I'm so glad that you're here. And then Mackie Johnson, who has a tremendous resume, a licensed clinical addiction specialist among other licensures that he has, and to hopefully talk to us a little bit about addiction and substance use disorder and how to get help and hope on the other way. So our goal here today is really just to understand the impact of fentanyl, to share information and hope to prevent some tragedies. You know, we were talking before we came on, if we can save one life today, we will have met our goal, and I think we may do that with this panel that we have here. So, you know, here at the U.S. Attorney's Office, we see fentanyl through our cases, and so sometimes cases become impersonal and statistics and things like that, but we see it really at every level. I mean, in the last 2 or 3 weeks since August started, we had a case that was a top cartel, Sinaloa cartel affiliated distributor of fentanyl, bringing in tons of counterfeit pills. It's caught with 133,000 pills of fentanyl, and then in the same week or week later maybe, we saw Burke and Catawba County kind of street level drug dealers distributing fentanyl. I mean, we just see it really everywhere. I mean, there's a hotel, we can see the airport from here, a hotel outside the airport where 2 illegal aliens from Honduras were distributing fentanyl out of hotel rooms there. So we really see it everywhere. And Eric, I know you were involved. This spring we had an operation called Operation Spring Cleaning. And so in the summer months we see more drugs and more youth with drugs because they're out of school, the weather's warmer, people are out on the street, they're doing more stuff. So to try to get ahead of that, we had this operation in the spring to try to get the drugs off the street, the guns off the street, and some of the worst actors off the street. And I was looking back at the statistics. It was a 3-month operation, and DEA mostly seized, I think, 254 kilos of drugs, but 22 kilos of that was fentanyl. And, you know, we talk about kilograms, and we talk about it with sentencing, and it doesn't mean a whole lot, but a fatal dose of fentanyl is 2 milligrams. That's enough to fit on the tip of a sharpened pencil. Like, it's a teeny tiny amount. So that 22 kilograms in those 3 months that you all seized was enough to kill 11 million people. That's the population of North Carolina. That could wipe out the whole state just from that 3 months of fentanyl. So it's just so widespread and everywhere. And I thought we'd start with you, Eric, to talk a little bit about kind of the nitty-gritty of fentanyl. And tell us first, you know, you see all sorts of drugs. You see meth, you see cocaine, you see fentanyl, you see it all. Why is fentanyl different? What's so unique about fentanyl?
Well, first of all, thank you for having me, Russ. I appreciate it. I look forward to the conversation with everybody. And like you said, if we can save one life or just bring some good information to the public, this is well worth it. So thank you. So fentanyl, I think, is unique because of its potency, really. And it's just a small amount can kill an individual. Like you said, the amount that can go on a tip of a pencil. I like to say just a few grains of table salt is enough to kill some people. So you never really know. It may be a fatal dose, it may not, but it's literally the potency and the availability. There's just so much of it. It's a synthetic, so it's easy to make, and that's the problem. That's what we're here to discuss.
Yeah, so when you say it's easy to make, I don't really have a full understanding of how fentanyl gets there. I hear about precursors from China, I hear about the cartels in Mexico bringing it in. Can you kind of walk us through the steps to get fentanyl to a person?
Yeah, to get to our streets. Yeah, absolutely. I mean, that's an important concept to kind of understand. So we're obviously battling the transnational criminal organizations, the cartels, that are really just, they're Fortune 500 companies. They're trying to make billions of dollars. They are making billions of dollars selling drugs. So they'll typically take the precursor chemicals. They'll get them from China, India, other locations, wherever they need to, wherever they can get them, wherever they can source them. They bring them to Mexico. Many times they have super labs, they have their chemists, they have their people that will synthesize and make the fentanyl from the precursor. And then they do different things with it. It might just be powder fentanyl, like we talked about, we seize the kilos of fentanyl, or they might mix it into other types of drugs, such as cocaine or methamphetamine. And then we're into the traditional smuggling networks. It comes up to the border many times, through the southwest border into the United States. Highway systems moving all through the United States to distribute. And also, maritime, it'll go through, to ports, Miami, up the East Coast, West Coast. It's really, smuggling is one of the oldest professions, so you can imagine, any way they get it in the country, that's what they do.
And so, and I know it's odorless and tasteless and all of that, and Mr. Johnson, you may say about this too, because I hear about, especially kids, who are really taking, they think they're taking an Adderall or an oxycodone, or sometimes it's a Skittles or something, and it's actually fentanyl. Do people know they're taking fentanyl when they're taking fentanyl, or is it more often they think they're taking something else and they end up with it?
I think it's a little bit of both.
Yeah.
I think you'll have people that are suffering from addiction that will seek it out because of its potency, because of the high they get from it. But I think there's a large percentage, probably most of the public, don't know that they're intentionally taking fentanyl. And I think that's really on the margin here. That message we're trying to get to everybody, but the people that are out there taking a pill, from a friend or somewhere, they buy from the internet. That's the message we have to get to them. It could contain a lethal dose of fentanyl. They have to understand that. And we see that going, a lot of times the pills are pressed and made in Mexico from the super labs that we discussed. They come across and they look like legitimate pills. They look like something you and I would get, from a prescription from our doctor, but they are not. They contain, many different chemicals, many different things that are not in the real pill, and they can contain fentanyl. So unless you get your prescription from your doctor or your pharmacy, you have to assume that it's tainted and potentially tainted with fentanyl, a lethal dose of it.
You have to assume that. So there's no tell. If you look at a bill and it's a fentanyl pill or an oxycodone pill, you can't tell the difference.
There's so many times that we've seized pills, fake oxycodone or counterfeit pills, and we put them next to a real pill, and they're almost indistinguishable. The color might be off just a tint, but maybe not.
You wouldn't know, yeah.
No one's going to know that. I wouldn't know it, but probably most doctors would look at it and say, I don't know that I would be able to tell the difference.
Are dealers on the street selling real oxycodone at the same price as fake fentanyl oxycodone, or is there a price difference?
What seems to fluctuate depending on where you're at. The real ones are harder to get, so they can be a little bit more expensive. I see most of the market, it's just easier to get the fake counterfeit pills, sell them at a discount, because you have more customers that are interested in a cheaper product, and they're getting the high from them. So the real ones can be a little bit more, but they're more difficult to get.
Well, and one thing, especially for the parents out there, is we think about drug dealing as happening on the street corner or whatever, and these shady deals and all that. A lot of people say, well, my kids would never do that. But we're really seeing drug dealing happen by social media now, right? People connecting with people over social media and getting these things.
Yeah, it's the world of technology. So, not that the old days of going to a street corner and getting drugs, that still happens. But we're in a new world with technology. So, and especially our youth, they're so used to being engaged with technology, and they're comfortable, whether it be through video game platforms or just using social media platforms on their phone. They're interacting with bad actors and bad people, and they can get these pills. Sometimes they're marketed to them as real pills, like, hey, this is a real oxycodone or a real whatever, and it's not. And sometimes the seller doesn't even know. They picked it up. They got a bag of pills. And your friend too. That's the point I like when I really discuss with the youth. I like to tell them, your friend might have the best intention. They might tell you, oh no, this is a good pill, or this doesn't have fentanyl.
Yeah.
And maybe that's what they were told, but they don't know.
Yeah.
They don't know.
And that's some of the saddest cases to me, are kids who are stressed out, they have exams coming up, they need an Adderall or something so they can focus, and they go and they get it off Snapchat or Instagram, whatever it is, and then they're on fentanyl, and in a worst case scenario, they lose their life, and in a best case scenario, they have an addiction that they've got to deal with.
That's right.
So I know DEA does a lot to prevent that. You have the One Pill Can Kill campaign, which is definitely true. Fentanyl Free America started recently.
Yes.
Are there any kind of tidbits you want to leave with the public from those campaigns?
Yeah, I think we started a few years back with the One Pill Can Kill.
Yeah.
I think it's a very, very appropriate slogan. Hopefully catchy, because we want people to remember that. That's kind of what I was, discussing with you in the panel here. Is it's just that one pill, and you don't really know what it is.
Mm-hmm.
So if we can market to our youth, that awareness campaign, we can tell them, get in their mind that one pill can't kill you. Whether you think it's ecstasy, or maybe you think it's something else, it may not be.
Mm-hmm.
And we're seeing where they're coloring the pills, they're making them more marketable towards our youth. You just have to really remember that one pill can't kill you. And we've kind of built on that awareness campaign into as you mentioned, the Fentanyl Free America campaign, which is just a little bit more broader. Obviously, it still encompasses awareness, but we've hit a little bit harder on the education and prevention piece, and then really the enforcement piece for DEA. That's the enforcement part of what we do in DEA. So just having a recommitment to really focus on cartels and the people that are bringing this poison to our streets. That's what Fentanyl Free America is.
And you've seen some results, right? I mean, you were sharing some stats with me that's really the same number of pills out on the street, but the amount of fentanyl in each pill has gone down, and the purity of the powder has gone down, which does save lives. I mean, it makes it less likely that one pill will kill, although, as you said, it's only a few grams of people sold.
Yeah, you're really rolling the dice. It's a gamble if you're going to take the pill. That's really the takeaway. Just know that if it didn't come from your doctor or pharmacy, you take it. You're playing Russian roulette. It's putting your life in your own hands.
Yeah. So is there any? I mean, I know you deal with a lot of cases, a lot of drugs, and a lot of sad stories. Is there any investigation or story that sticks out in your mind that you want to share with people?
It's so much tragedy and sadness around this epidemic and the fentanyl. But I would say for me personally, we have in our DEA headquarters, we have a Faces of Fentanyl wall. Mm-hmm. It's actually several walls, and a lot of the people that end up dying from overdoses, their families send in pictures of them and stories about them, and it's a way for us to remember what we're doing this for. But when I see those faces, and particularly the young faces, it really hits me hard, because you get to see that their lives were shortened by so much, and they missed so much because many of them just took a pill and they didn't know what it was.
Yeah. Well, that's inspirational you put the faces there, because I think it's so easy in our line of work to look at cases and statistics and stuff instead of people, which is why I'm so glad these guys are here, because they do deal with people. And Dr. Hines, you deal really with people every day as an emergency room physician. You don't know who's coming in to see you every day, and we're talking about one pill can kill. And so what worries me is my child or niece or nephew, or I'm sitting on the city bus and I see someone on the school bus and someone's overdosing, and I don't really know what that looks like. Can you tell us about what the signs of an overdose are?
Yeah, so opioid overdose, which fentanyl is a portion of, so they all kind of play the same role in the body, and it kind of slows everything down. It's a good way to think of it. And so the biggest thing you're going to see is slow breathing. And so even up to not breathing, a lot of times you'll actually hear a gurgling sound or a coughing sound can be very common there. One of the more common things we see that a lot of people recognize is the pupils get very small and constricted, so we call those pinpoint pupils. You may see that, and that's kind of one of your telltale signs that there may be an opiate on board. People, because of the not breathing, they can start to turn blue around the face and the fingertips. The first place you're usually going to see that is the lips. And so right around the lips, if you start to see that, that means they're not getting enough oxygen to the body. People can get clammy, cool skin, decreased responsiveness in terms of seeming really sleepy. Signs can be subtle, but people just kind of seem like they're a little out of it.
And so I imagine there are cases like that where you see that and you think, well, they need to sleep it off, or they need some water, they'll be fine. Kind of like a reaction to alcohol or something like that. Is that ever the case? Like, is it ever okay to say, let's just keep an eye on this person and see what happens?
Yeah, with opiates, we would certainly not recommend letting someone sleep it off. We talk about with things like stroke and things like heart attack, time is brain, time is heart. It's truly the same thing with opiate overdose. Well, time is brain. You are losing oxygen to your brain because you're not breathing. So the more time you allow someone to sleep it off, the less time their oxygen is getting brain, the less time their brain is getting oxygen, and you're going to have a bad outcome from that. So that's why we talk about things like naloxone, which we'll hit on a lot, I think, today, and the importance of that, and the importance of knowing how to use it, knowing where it is, being able to activate 911, and be staying with someone, and not allowing someone to just kind of rest there by themselves.
So tell us more about that. If I'm sitting on a city bus and I see all the symptoms you just told me about, what do I do?
Yeah. So there's a quick tip. Naloxone is great. It's not everywhere. I'll say that. A quick tip, though, is what we call a jaw thrust. So if you go just behind the person's mandibles or go behind their jaw and thrust up a little bit, that will help open up their airway and help them protect their airway and help them breathe. So that's often first step, is just get someone a little bit in a better position. If you have naloxone, that's a huge step. We're seeing it more in the community. Police are carrying it. We were talking before, a lot of people are carrying it now, and it's available on things like city buses, and it's there. And naloxone is a nasal spray. So it is, like I said, readily available. There's lots of different formulations of it. The more common one would be a nasal spray. Comes in a couple of different doses, but in general, you literally just spray it up the nose, and it starts to work from there, and then you can continue to monitor someone. But it's almost instantaneous. Within seconds to minutes, you're going to start to see effects of that.
And naloxone, that's Narcan is one of the brand names for that. So that's for people who don't know it. Can you tell us at a very high level, because we're not doctors, but how it works? I'm just so curious about what's happening in the body once you administer a nasal spray of naloxone.
Yes. So naloxone is the antagonist for the opiate receptors in the body. So fentanyl and oxycodone and roxicodone are these things that the pain pills like that work on receptors in the body called opiates that give you that pain relief, and that high is one of the other things that you see with those receptors. So that naloxone actually binds to that receptor and turns it off and inactivates it. So it reverses the effects of those opiates. It's an incredibly strong, we say it has a high affinity for those receptors, so it's an incredibly strong binding such that it can actually kick off most of the other agents that are in the body, including fentanyl, including all the other derivatives of that. And so it can reverse things even if you have those incredibly strong agents on board.
That's amazing. Is there any situation where you should not use naloxone, where it might cause a negative reaction or something if you're not sure you should not administer it?
In general, naloxone is very safe. Talking higher level, there are some thoughts that if you give naloxone, you can potentially put someone into withdrawal that's been on long-term opiates. But in general, you're very safe. If you have concern, nobody would ever fault you for using naloxone.
So if you see someone you think is overdosing, you do the thing you told us behind the jaw. Use naloxone if you have it, or if you can find it around. Obviously, call 911. So is there anything else people should be aware of or doing in that situation?
Yeah. So, I certainly want to call 911, certainly want to stay with the patient. I think it's important to highlight, too, sitting here with law enforcement who do an incredible job, there is Good Samaritan laws in North Carolina. And so it's important for people to realize that if you see someone overdosing, you can't necessarily be prosecuted for small amounts of possession there if you are the one that calls 911, if you stay with the patient. So it's really important, and what we say is to stay with the patient and stay there and protect them and stay with the person who's overdosing and receive that emergency response.
That's a great point. So if you and I both took a pill and you started overdosing, I'm not going to get in trouble for calling the police and saving your life, which is a good point, because I'm sure that would run through someone's mind for sure. So in the emergency room, you probably see a lot of patients coming in off opioids and fentanyl and all of that. Are they overwhelmingly young or of a certain socioeconomic status or from a certain neighborhood? Are they all over? Like, are there any patterns that you see?
We truly see it across all forms of life and all socioeconomic statuses. And so you see your high school quarterback and your grade A type straight A student can all be in contact with these pills. And like we were talking about earlier, part of the problem is that they're so readily available and they are what we call laced or pressed with other pills that you think are just normal pills that you can buy from a friend. So you really truly see it in young people, you see it in the elderly people as well. You see it in middle age, you see it across all ages, across all socioeconomic statuses, and it really sadly doesn't discriminate.
Yeah, that is sad. And, we're talking about pills a lot, but we're seeing other drugs laced with fentanyl too, right? We've got cases of marijuana that's laced with fentanyl, and then you could be thinking that's harmless, and instead you're getting fentanyl.
Yeah, I don't know all the major drugs. I've seen reports or lab reports that they've been laced with fentanyl. So marijuana, cocaine, crystal meth, anything can be laced. And you have to assume that. I mean, you're taking. It's not good to use those drugs anyways, but you're taking your hands, your life in your own hands, because you're using it to cut it for potency and addiction.
Well, I think that's such an important point too, because there are people out there that say, well, yeah, fentanyl's terrible, but don't worry, I'm just smoking weed or whatever. But maybe not.
Maybe not. Yeah.
So, well, as just
I can't count how many conversations I've had with individuals that would come in and we would give them a drug screen. So you're positive for fentanyl. And they said, no, it wasn't. That's not what I was taking. I can't count how many of those conversations I've had. It's everywhere. It's in everything. And like you said, if you don't get the pills from the pharmacist in the pill bottle, don't take it. Don't take it. If it comes from the drugstore, if it's not wrapped up in the box and it's not, the seal's not, don't take it. You just don't know. You don't know what's in it. It's everywhere.
Yeah, and that's such a good point. And like you were saying, even if you think you get it from a legitimate source, you don't know that your source got it from a legitimate source. I mean, it's really kind of terrifying. So, is that your experience in the emergency room too? That people often don't know it's fentanyl?
Yes, absolutely. I think Xanax is one of the huge ones. Alprazolam is one of the big ones. We see people at parties or just trying to get a little relaxation, and it's laced with fentanyl. And it's important to notice. It's very confusing to me when this kind of first started. But why would you put fentanyl? I couldn't figure out why would you put fentanyl in this, but it's so cheap to make, and it can be mass produced, mass distributed. You can get these pills for a lot cheaper and create them for a lot cheaper and then still sell them for the same price. But also you're throwing this agent in there that who knows what it can do to you.
Yeah, well, the Xanax is such a good point too, because I'm sure you all have heard tragic stories where people lose a family member or whatever, and they go to a friend and say, I just need one Xanax, just like get me through tonight. My husband's not in the bed next to me or whatever, and instead they get a fentanyl pill and they think so much worse. So, well, for the parents out there, what's one thing you would want them to know? As an ER doctor, having seen what you've seen, is there anything that comes to mind that you would tell a parent?
Yeah, I think we have a lot of work to do on just decreasing the stigma of addiction and mental health, and I think that's a huge component of this as well. And for parents, you want to say, my child would never do that, but that's where we get into this conversation of these pills are everywhere now, and so it's not just you're going to go out and inject yourself with heroin anymore. That's hardly ever used anymore. And so you're seeing these synthetic drugs and synthetic pills, and it can truly happen to anyone. And so with parents, it's so important to have that conversation. You always want to have that conversation before something happens, as opposed to afterwards. And it's a hard conversation to have, but it's an easy conversation to have at the same time. And you got to look out for those signs like we talked about earlier. But you want to talk to your kids and just bring it up and say, hey, raise awareness. This is out there. If this is something you see, here's the dangers and here's what you can happen, and you can truly save lives just from a simple conversation.
No, that conversation is so important because there's so much people don't know about fentanyl. It's relatively new, and certainly if you're a kid, you don't know that maybe that Xanax or that marijuana, or I met a mom whose daughter drank out of a water bottle and it had fentanyl in it. How careful you have to be.
Yeah.
So, Dr. Johnson, tell us a little bit about these conversations. Give us some guidance about how we should engage in these conversations with our children, and not just our children, but our loved ones, our relatives, everyone we kind of encounter.
I think the most important thing is to talk about it, because if you have suspicions, if you have concerns that my family member, child, son, daughter are using it, talk about it. It won't go away by saying you can't wish this away. And sort of the stigma, that's my child would never do that.
Yeah.
It's not about good, bad, right, wrong. It's just the fact of life and death. It's everywhere. So talk about it. Addictions live in the shadows. Addictions like to hide. So that's why I say talk about it. when you're a parent looking with your kids, you're looking for sort of the telltale signs that they might be using. Changes in appearance, changes in behavior, changes in school performance. You're looking for all of those changes. Another thing to pay really particular attention to is open your ears when you're listening to your child talk. Because one of the biggest indicators that a child might be at risk of using drugs or using drugs with the people that they're hanging out with. So friend Johnny, if my child comes home and says, well, friend Johnny's got in trouble at school for having fentanyl, or, you wouldn't believe what they did at the party last night. The kids are often just talk about it. Keep your ears open, and if they're associating spending time with other kids that are using drugs, they might not be using it, but their risk of using is increased significantly. But the main thing is talk about it, talk about it, talk about it. If you have specific questions, call a professional. Ask them to do a session with you. There's evidence-based practices out there that different organizations will come into the schools and offer to families at free or no cost that are out there. So just seriously use those resources. But again, just listen and talk. I think those are the biggest things that you can do.
Yeah, no, that's really helpful. Listen and talk. And, we talk about one pill can kill, and it absolutely can, but a lot of times one pill doesn't kill, but it causes addiction. And so for anyone who's watching today and maybe is struggling with addiction or knows somebody who's struggling with addiction and doesn't know what to do, what would you tell them is that first step?
Well, if it's fentanyl, I think the first step is you need to get medical stabilization, because the withdrawals from fentanyl or opiates are pretty intense. So you've got to get that stabilized, because if you don't get that medically stabilized, the person's just going to be going through the cycle of using, getting sick, using, getting sick, where it turns into this routine of using to not get sick, and that's where you'll see a lot of the compulsive behaviors, and that just doesn't go away by itself. So medical stabilization, but that by itself is not treatment. That is not enough to get someone into recovery. You need to get them stabilized, whether that's in an outpatient like detox setting, or if that's going to an inpatient detox setting. Get them stabilized, but then following up with treatment. Treatment works. It's very effective. The success rate's between 40 and 60%. And one of the key factors to successful treatment is how long someone's in treatment. If I can get somebody to stay clean and sober for a year, 365 days, their chance of relapse drops significantly. And then you see around 5 years, you see another major decrease in their chances of relapse. So time is the gain. Time is the gain here. Get somebody in, get them stabilized, get them comfortable, and then start working with the treatment provider on sort of what the long-term plans are. Treatment works. It's out there. It can be very effective. So I might have gone off target a little bit.
No, not at all. But I want to, on the medical stabilization, because that can sound kind of daunting to people, I think. And Dr. Hines, you probably can jump in on here too. But what does that look like for someone who's saying, I don't know, I might just keep this thing going. I'm a little worried about the medical stabilization. What does that look like? What is the course of care for that?
So a lot of people will try to quit cold turkey, and frankly, it just doesn't work, and we know it doesn't work. And exactly like you said, as soon as those withdrawals hit, you got to go get that, that next high to prevent those withdrawals. So we have to have a little bit of a mindset shift over the last several years, and we have, and I think we're getting there, but we have to continue to work on this, that this is truly a lifelong treatment of mental illness, of addiction, which is changing your brain chemistry. So you can't just say, I'm going to take a pill for a day or two, get off of this, and then be done. I tell people, you're going to have to treat yourself just like you treat your high blood pressure, or just like people that are diabetic. You have to think of this as you are treating yourself for an addiction, which is truly, again, altered brain chemistry. And so the main substance that we use, the main, medication we use is called buprenorphine. and it is highly effective, and it is a medicine that a lot of people have hesitancy to use, but it is safe, it is effective, and it truly works for people, but you have to stay on it, and you can't take it for a week and then go off of it and think you're fixed. Just like you said, it's a long-term process, and you have to treat yourself just like we treat all other medical illnesses.
So where does that hesitation to use it come from? Is there rumors out there that it has negative side effects? Or?
You may be able to answer this a little bit better. I think it's a lot of stigma, though.
It is a lot of stigma. I just want to say before I jump on that, I did want to caution, those rapid detoxes where people go in to be detoxed for 5-7 days or just go cold turkey. There's a real danger of overdose there because the most risky time for overdose is resuming use after you have been detoxed or clean and sober for a brief period of time. Your body, when you stop using, your body loses its tolerance or its internal defense against opiates, and it'll lose that pretty quickly. So if somebody goes back and starts using an amount that they used to use, it can very easily put them in an overdose situation. So that's just real important. What I hear mostly is I don't want to be on something the rest of my life, and it's just another drug. Like Dr. Hines said, there's been a significant shift, especially with opioids, looking at it as a lifelong condition. In my mind, I look at it as the same way as managing diabetes, hypertension, obesity. It's the same thing. And what's fascinating is the success rates are the same.
It is fascinating.
For these behaviorally based, I call them behaviorally based medical conditions, which addiction is, and these other ones that I just mentioned are. But the success rates, the positive outcomes are about the same, which I find fascinating. So it's the same idea. It's the same idea. Take a medicine. If somebody has diabetes, you're not going to give them a hard time about taking their metformin or their insulin. You just take it. Right?
Yeah. Right.
So I think there's the shift in the conversation is starting to happen. So we're starting to move away from, well, I'm just trading one from another. I don't want to be on methadone. I don't want to go to the clinic every day at 5 a.m. Stand in line with the other drug addicts and things like that. The treatment options in the past 10 years, we've got a lot more of them. They're a whole lot better. They're a whole lot less stigmatizing. They're a whole lot more friendly to you living kind of life that you want to.
Well, that's great to hear. So if someone out there, you've convinced them, they want to do it, where do they go? Do they go to a counselor like you? Do they go to the emergency room? Where do you go to start?
Yes.
Anywhere.
Anywhere.
Just go.
Call a counselor. Talk to your primary care physician, because I promise you the primary care physician has probably had this conversation with other people today.
Yeah.
Talk with them, and they can hook you up. If it's a life-threatening emergency, go to the emergency. Go to the emergency department. But you have to pick up the phone, call somebody, primary care doctor, call an counselor. Those are two great places to start.
Yep. And it's so much easier. They've improved access so much. Just like you're saying, there's so many more options. We've also improved access over the last 5 to 10 years. When I first started, you had to do a special training course to prescribe buprenorphine and get what you called an X waiver to even prescribe it, and they got rid of that now. And so anybody can prescribe it. Your primary care doctor can prescribe it. An emergency doctor can prescribe it. As long as they're willing to do it, which most are, is what I find now. It's available and it's out there.
Are there any fake products out there that people get going around the medical system? Kind of like they're getting fixed oxycodone. Are people getting fake drugs to help them get off fentanyl?
I'm sure that exists to some extent, but the great thing about buprenorphine is the formulation that's used the most commonly actually has naloxone in it. And so you can't overdose on it because you're taking naloxone at the same time. So it still works because it's a different type of mechanism, but you can pretty safely assume, as long as you're getting it from a reliable source, that you're good to go.
Interesting, there is a black market for Suboxone in the community. And there is a diversion risk there. But what people are doing, and you got to ask the question, well, how bad is this? What you're doing is people are keeping it, keeping a supply of it in case they run out of drugs so they don't get sick. So there's a real market out there for Suboxone too. There's a diversion criteria there, but it's different. Fundamentally it's different. It's not I'm trying to get high using it. I'm using it to keep from getting
had a question. You had mentioned the relative safety of naloxone and Narcan. Going back to what Russ was saying, you're on the bus, somebody you think they're having an overdose. Could it be appropriate to give them more than one dose of it?
Yeah, I actually wanted to bring that up at some point, but the potency of what we're seeing out there, and you see this every day, is very high right now. So yes, more than one dose is absolutely appropriate. I'll be quick. I know we're running probably short on time, but a little anecdote I'd like to tell people previously is I haven't been doing this for that terribly long, but when I first started, I was trained that we were giving naloxone in 0.4 or 0.1 milligram aliquots and just slow pushes at a time, and you don't see anyone giving less than 2 milligrams now. So we've tenfold increase of those doses just starting, and most of the commercially available products are either 2 milligrams or 4 milligrams. I think the majority are 4 milligrams now. When I'm in the emergency department seeing a patient, we usually will start with the 2 milligrams, but I do not anymore consider it a failure of naloxone until I've gone past 10 milligrams.
Wow.
And we're not having any effect anymore. And so I have given that much and seen effects, and it's out there. Fentanyl is one of the more higher potency. We're seeing a lot of different agents out there that are so much more potent than your run-of-the-mill oxycodones and roxycodones and heroin that we used to have. Fentanyl was step one, and now we're even going beyond that. So the doses are, you can't give someone too much necessarily for the most part.
So how do you know to give someone that second dose?
If they're responding, if they're not responding, or maybe they respond a little bit and you see that maybe they open their eyes at you, but they're still not quite there, still not quite answering questions, the second dose would probably be appropriate.
So how long does that take? Once you administer the naloxone, how long should you wait before you're expecting to see a reaction?
It's very quick. It's within minutes. Oftentimes, even within 30 seconds to 45 seconds, you're going to see a result if you're going to see a result.
Okay. Interesting.
Also, another thing about naloxone is stay with the person until help gets there, because you can give somebody naloxone, they can respond to it, they can wake up. But depending on how much they take, and they can go back into an overdose state and might need additional doses of medication. So stay with the person until help arrives. A lot of people don't realize one dose and then you're good, and
right.
it can take more.
So it's switching gears a little bit from the person on the bus that you run into or the people you know. And you talked about parents and what they should look for in their children. I have two questions for you. One, are there signs I should look for in coworkers and acquaintances that they're maybe struggling with this? And then how important is it, or how much does it help to intervene early in their addiction?
I'll answer the second question first.
Okay.
Just like any,
Yeah.
we're talking about stigma earlier, and we're talking about looking at addiction the same way we look at other chronic medical conditions. The earlier you can intervene, the earlier you can start talking about it, the earlier you can provide services, the better. You can't talk about it too much. So yes, early is better. It's just like any chronic medical condition. The earlier you get started with it, the less severe the addiction or the disease state you can intervene and prevent from getting to a severe state. So yes, early, talk, listen. It won't go away by itself. So talk about it. For your coworkers and adults, it's really kind of the same thing as kids. You start to look at a lot of behavior. Are they missing work? Are they suddenly irresponsible? Are they not fulfilling their life commitments? Are we having money problems? What do they look like? Are they losing weight? Or is their color bad? Are they starting to have skin problems that are uncharacteristic for that individual? And that's really it. Just eyes open, listen to them, and then just pay attention to their behaviors.
So if someone's watching today that knows someone like that, or maybe someone themselves, and they're afraid to ask for help, what would you tell them?
What I typically do with people that are kind of on the fence when I sit down with them is we're trying to instill hope that there's a life without drugs. that there's a life that is better than what you can visualize right now, because you're stuck in that cycle of use, not getting sick, use, not getting sick, and that becomes your whole world. There's a whole life out there. You can become part, you can rejoin life, you can get the life, the satisfaction, the joy that you want out of life. Also, there's good treatments out there. This cycle of sick, using, you don't have to live that way. You don't have to live that way. There are effective medications that can make you comfortable, and a lot quicker than you can imagine. We can get you back on the road. We can get you on the road to recovery.
Yeah. You know, I was reading some of your stuff before today, and I saw that you said there's a life better than you can imagine that's out there. That was kind of inspiring to me.
Right. Hope,
Yeah.
right? That's why we get up each day. That's why we go to work. That's why we have kids. That's why we live the American dream, right? It's for hope, and that's what we're trying to do is reestablish hope in people, reconnecting people with their hope.
Yeah, well, I love that, and you know, we could talk all day about fentanyl, but I think you brought us to the perfect place to kind of close this out, maybe for each of you, to give in a sentence or two, not super restrictive, but briefly, what gives you hope when we're talking about fentanyl and addiction, all this terrible stuff?
Yeah, we've come so long in the last 10 years. I've been working in this field for 30 years now, and I remember when the opiate issue first started, and watched it develop over time. Over the past few years, we've started, even though overdose deaths are high, we're starting to see a significant decrease in overdoses and overdose deaths. And it's because the medicine's out there, the naloxone's out there, the education's out there. The one pill can kill, the DEA is doing their job, everybody's working, and all of these initiatives that we have been working so hard on in the past years are starting to grab hold. So that gives me a lot of hope, is that we're hopefully as a community, hopefully as a community, we're starting to come out the other side of this dark time.
Well, I hope so, and you're certainly part of that, so thanks for all you're doing. Agent Conway, what gives you hope?
I think it's this.
Yeah.
We're at the point where we're having conversations, we're working collaboratively. It's not just a law enforcement issue. We're never going to arrest our way out of this problem. We have to work together. We have to understand how we can help each other and build each other up. Almost a little bit of a shameless plug too. I want to go back to you said talk. The awareness is such a big piece of this. We want to get to it before they get addicted. We want to get it, get to our youth before it gets to the street and gets in their hands. So if there's parents out there, educators, if they're looking for resources, they can go to DEA.gov. They can see the One Pill Can Kill campaign, the Fentanyl Free America campaign on there. There's toolkits, there's resources. Talk to your kids, talk to your youth, talk to your family members. Go to those websites or anywhere you can find information and initiate that conversation. And I think that's happening more, and I think that's what gives me.
Yeah, that's wonderful. Well, at the end of a long 12-hour shift in the ER, Dr. Hines, what gives you hope?
Well, I'll echo what they said, and I think just to kind of summarize it, I think we as a community have become more proactive for this, as opposed to previously, historically, we were very reactionary to this epidemic and this issue and trying to catch up. And I think we're getting to the point now, like you said, numbers are dropping. They're still high, but numbers are dropping, and we're seeing progress, and we're making progress. And I'm now having, Narcan and naloxone being given out in the field and being able to talk to parents and say, hey, we fixed it this time. We got it. You still have your son. You still have your daughter. We didn't have those conversations previously. And so we're getting to the point where there's nonprofits out there. There's naloxone being offered everywhere in your health department, at the pharmacy, in the emergency departments, at clinics. It's available and it's accessible. Buprenorphine is available. Methadone is available and accessible. These treatment options are there, and we are slowly but surely, I do think we're making progress, and we're getting there.
Yeah, that's good to hear. Well, I'll tell you what gives me hope is all of you guys. I mean, this is not a conversation that probably would have happened several years ago, and the compassion in the room from law enforcement and from doctors and from counseling. It's not oh, your kid shouldn't have done that, oh, they're hanging out with the wrong crowd, oh, you should have been more careful. It's really a compassionate conversation with the community, and I think that is what's going to give us progress. So to anyone out there, awareness saves lives, conversations save lives. If you're struggling, 800-662-HELP is a place to start for help. Thank you for joining us on our first Facebook Live. Thank you to everyone here for raising awareness and joining us on Fentanyl Prevention and Awareness Week that we've made. It's really Fentanyl Awareness Day on Friday. So thanks, everybody.